welcome from Philip.
Hello, everyone. Welcome to the 2023 FSGS Conference. I apologize for the way that I'm currently dressed right now. I will be going through surgery tomorrow. But I just want to let you know that you are in for a awesome treat to be able to get this information on FSGS from not only professionals, but from three wonderful, outstanding women that have had this disease for a number of years. And these three women I've gotten to know over a good amount of time and couldn't have picked anybody better to be on this panel. To the presenters and the panel, thank you very much for taking the time out today to assist with educating the people on this disease. To my guys, to Farrell Cook and Fred Hill, thank you publicly for taking the time out to host this wonderful event. And definitely looking forward to watching this when I come out of surgery. I know it's going to be an awesome event. So, with enough of me talking, let the conference begin, and everyone have a wonderful night.
All right, now we have the opening by Shannon Mulroy.
Hi. Thank you for having me. I'm excited that Philip asked me to come open this conference up. And I'm new to this panel here, but I appreciate you listening and taking the time to hear a little bit about my story. So my name is Shannon. I'm out of Long Island, New York, and I have a now 20-year-old daughter who has FSGS. Our journey began when she was 15, a freshman in high school, when we were blindsided by this rare kidney disease called FSGS. At the time, we had the same normal symptoms that everybody else had, the swelling of the eyes, gave her some Benadryl thinking it was allergies. Unfortunately, 2 years later, she was in full-blown end-stage kidney failure and on dialysis. So nothing had worked for her. She became steroid resistant, and we tried everything, but in the end, she ended up on dialysis. She received the gift of life by a non-related living donor, and shortly after, she had recurrence. The FSGS came right back and attacked the new kidney, so our battle continued. We went through hundreds of plasmapheresis, leukapheresis, all sorts of different anything, throw spaghetti against the wall, see if it sticks type of stuff. Ultimately, we ended up having infusion called ofatumumab combined with another medication, and that's really what helped her start the process of being into partial remission. So this June will be 4 years post-transplant. She finally, about a month ago, hit remission, and we're real excited about that. Myself and my husband are both we're both altruistic kidney donors, and we received 2 vouchers for her next second and third transplants, and we're pretty excited about it. I call her Willy Wonka golden tickets. So again, I'm happy to welcome everybody to this FSGS conference, and I'm excited to sit back and listen to y'all.
Shannon, just want to say thank you. That is an awesome, powerful story. For those of you, myself, my name is Fred Hill. I'm one of the hosts. Real quickly, for me, I'm the author of Dialysis It's Not Your Life, available on Amazon.com, the book and the workbook. I'm also the founder of Reset Life Counseling, and actually, what we do, we have our goal is to counsel and coach, empower dialysis patients, kidney disease patients, transplant patients, kidney transplant patients, and their families, because kidney disease and dialysis, it affects more than just the patient. Myself, I was on dialysis for 3 years. I did peritoneal and I did the hemo. And for my story, as I was going through, no one really ever looks at the wife and the son. My wife and son, they were going through having a hard time in school, things dealing with marriage. We all know how it affects the body. And so for me, once I got my kidney transplant, I became an advocate. And so went and got a lot of training, and now I'm a certified counselor coach, and we coach families. We do group sessions. Also, it's a 5-week reset empowerment program, and we do not really go over about the medical part of dialysis. What we do, we talk about living, because you're on dialysis does not mean your life is over. You can get your love life back, sex drive back, get sexy. You can go on vacation, your hopes and dreams, everything, get it back while you are on dialysis. And so with the 5-week program, we go through that and we teach with the book and the workbook how to live and live big while you're on dialysis, while you're dealing with kidney disease, and also to build and as a team and community. That's what we do. So if you want to know more about Reset Life Counseling, check us out at dialysisisnotyourlife.com. Dialysisisnotyourlife.com. Well, now we have our first speaker of the night, Dr. Vohra. I do apologize. I won't mess that up, Dr. Vohra. And so we're going to get started tonight with the first speaker. Dr. Vohra, if you would take some time, tell us about yourself, and the floor is yours. And we just want to say thank you for being here today.
Thank you, sir. And what a moving story, Shannon. We appreciate you sharing the journey with us. So my brief background, that I'm in Massachusetts, since 2014, and I was working with Beth Israel and Leahy Medical Center, a big academic center. I practiced for 10 years before joining a value-based kidney care company called Monogram Health. Dealing with the dialysis and chronic kidney disease patient is a passion throughout the company. So one of our metrics, or one of our mark is, that we help patients going through the journey of kidney disease, providing support for the home dialysis and also providing support for the kidney transplant. We understand this journey is tough, but we simultaneously are the coach, are the physicians, are the practitioners for the patients of kidney disease, driving a better outcome. Coming to the disease specific thing, so FSGS, it's not that common, but we have seen multiple patients in our practice. It's called focal segmental glomerulosclerosis. It's a complicated name, and the name arises from the definition that, it causes some damage to the part of the kidney and also the part of the nephron, or part of the glomerulus, and the glomerulus is kind of a unit, just like a centimeter or a meter for a length. It's a unit of kidney. So once the damage happens, damage can be primary or secondary. And then the patient starts leaking a lot of protein in the urine. And usually the first symptom to arise is, the patient start having a foamy urine and some bubbly kind of a urine. So that's not the symptom to neglect. That's a very common symptom of patients with a kidney disease. And once the disease progresses from the foamy urine to a point, then patient starts having some swelling in the leg, some altered taste in the mouth, or some puffiness around the eyes. The patients may get a little bit more tired, and that's the presentation. That's a progressive presentation, and I would suggest everybody, irrespective of you have autoimmune kidney disease or any kind of a kidney disease, if you are seeing a foamy urine, that's a first warning sign, or a first alarming sign that you should see a physician and check the urine for a protein leakage. Our kidney is a very delicate organ, right? So every time from that unit, which I named glomerulus, or a small unit of a kidney, the protein leaks, is cause damage to the membrane. And the damage to the membrane is like that, that it does not recover well. So once the damage starts happening, the kidney loses ability to filter out the toxins, and then you start becoming a patient of progressive kidney disease. Human kidney, specifically the glomerulus or the unit, does not regenerate, right? So the part of kidney you lose forever. And every time the protein leak from that delicate structure called glomerulus, it causes the damage to the glomerulus. And so it's very important to see the signs, see the signs of the protein leakage. specifically, just like Shannon said, that her daughter is young, and it may start as a primary FSGS in the young patient, or a secondary FSGS, or in some cases a congenital FSGS. So the first thing is, like, ask a physician's opinion, ask an opinion from a specialist, and then the specialist is going to run over multiple tests, but a definite diagnostic test in patients of FSGS is the kidney biopsy. Without the biopsy, it's very hard to assess, what's happening in the kidney. And if we diagnose the FSGS based on the kidney biopsy, then we need to know whether the FSGS is a primary. That means, it's most likely an autoimmune related, or a secondary cause, right? The secondary cause can be related to maybe some virus, like patients of HIV, or patients of a virus called cytomegalo, and other viruses are there, right? Or simply some medication, some heavy metal exposure. Some medications can cause FSGS, which is secondary. And the most common secondary FSGS in America is related to obesity, because once you are too big and your basic metabolic BMI is around like 35, 40, 45, then the kidney can't handle the pressure, or the glomerulus, that delicate structure we talked about, it cannot handle the pressure. Once that happens, you start leaking the protein in the urine. That's obesity-related FSGS. The people who develop the primary or autoimmune are a little bit challenging, because this is an immunity-related outcome, and I'm expecting or suspecting that must have happened to the Shannon daughter. We're gonna get a little bit more history, but once it's primary FSGS, then it's a different treatment plan, because you have to calm down the immunity. The secondary, you have to treat the secondary factors. Somebody's on a drug for causing as FSGS, you stop that drug. Somebody has a full-blown HIV, you treat the HIV and all that stuff. The primary is a challenge because it's a kind of immunity related, and in such situation you have to calm down the immunity. Some people respond very well to simple measure like using the steroids, but there are patients or a specific subtype of FSGS in which using the steroids itself does not suppress the whole disease. You need something heavy duty, and which comes in the form of different immunosuppressants. Some are the same drugs as some transplant recipient uses, like cyclosporins, but the others who are a little bit not fortunate enough, have a collapsing or some other variant of FSGS, needs a little bit needs heavier immunosuppressant. And the problem of this disease is, that it can recur, just like Shannon explained the story, that if you have an FSGS, you can go into the suppression or the calming phase, and then it bounces back, and it can bounce back again, or it can be present again, even after the kidney transplant. So we have seen the patients, who are losing their kidney after the kidney transplant, because there is a recurrence of FSGS. And then comes the role of infusion, just like what she said. So this is the pathway, we pick, whether the primary FSGS, is showing its full-blown effect. But the basic idea is to lower down the leakage of protein in the urine, because you have to preserve the delicate structure in the kidney. And then those patients who have kind of a mild variety or kind of a tip variant, it's a different variant, you can use some medications just to prevent the leakage of protein, and use low dose steroids and see how patient is responding. But from the patient's perspective, it's very important. If you are having the protein leakage in the urine, you should be aware of the sign, and the first sign is a foamy urine. And I'm going to stop here and take the questions and go from.
That was really, really good, Doctor. First question I have for you is how does it attack the second kidney? Because I'm a 2-time kidney transplant recipient. My name is Tafaro Cook, and it attacked my second kidney as well. So I just want to know how does the FSGS attack the second kidney?
It's an immunity, so you can suppress the immunity, but like due to predisposing factors in your body, you can get the autoimmune reaction back, and that's how it happens, so it can attack at multiple stages, so that's why it's important, like to knock off that immune related reaction.
Okay. Is there anything that you can possibly do from this? I mean, I've been going through this since I was 18 years old. I'm 53 now. So I was wondering, besides the medications, my question is like nutrition, does that play a part in this also?
There are some kind of FSGS, in which the obesity and the diet plays the role. But I'm suspecting in your case, you had a primary FSGS, or something like immunity related. Not much we have available, like when you start having a lot of protein leakage, and Lindsay is going to tell you that, you can watch the diet, because, we want the patients not to leak too much protein in the urine. So we tell them to cut down the protein intake, from 0.6 to 0.8 or something in that range per kg, and then go from there. Control your blood pressure, because you don't want, and there are specific medications these days, what lowers down the blood pressure. Some ACE inhibitor like lisinopril, and there are SGLT2 inhibitor, the new classification of drugs, which have shown very good data controlling the leakage of protein. But the major point of target to stay the kidney healthier is to prevent the leakage. So the leakage is a damaging to kidney. The protein comes in the urine, it causes the kidney damage. So from the diet perspective, yes, blood pressure control, diabetes control, weight loss. But the immunity standpoint, you have to take immunosuppressants. There is no other way to calm down. So sometimes the patients, like Shannon's daughter, it relapsed so bad, that she had to be on infusion. People do the rituximab and the kind of drug she said, and all.
Right. Oh, okay. Does lifestyle? I know what you said about nutrition, obesity, and things like that, but is stress a part of this also? Can stress accumulate with these problems also in the kidney?
I mean, like the stress and lack of sleep has been associated, but like how much it has been a contributing factor is hard to say. So people more likely say the immune related rather than anything else.
Okay. All right. Thank you so much. I appreciate that. We appreciate the information. Thank you so much, Doctor.
Thank you so much. Thank you so much. Right now, Tafaro he's the second host. Tafaro, if you could take some time, introduce yourself, and
Yes.
Talk about kidney care coaches.
Okay. Hello, everybody. My name is Tafaro Cook. I'm a 2-time kidney transplant recipient who spent over a decade on dialysis. I had my first transplant when I was 24 years old after playing college football. My second transplant was in 2007, close to 15 years ago. So right now, what I do is I have a business called Kidney Care Coaches. And what we do is we coach people with stage 3 to stage 5 kidney disease. So what we do is we have 3 services. We have a membership site, group coaching, and one-on-one coaching. And our goal is focusing on coaching patients through their challenges with kidney disease. If they're stage 2, our goal is to get them to stage 1 or stay consistent with being stage 2. If they're stage 5 and they're on dialysis, our goal right there is to make them compatible and compliant so they can get a kidney transplant. I've been coaching people since probably, I did 15 years with the Why Not Foundation. That's when I was working with pediatric transplant kids throughout the country with them. And right now, like I said, doing kidney care coaches. We have several patients of ours, or clients of ours, I should say, that already had transplants, and they're thriving really, really well. They're on our membership site, and we also, like I said, we do group coaching and one-on-one coaching. So just wanted to say thank you to everybody for having me here, and looking forward to working with you guys. Thank you.
All right.
Thank you.
Also, if you could go ahead and introduce our second speaker.
Yes. So, introducing Justin Oveyssi. Apologize. Sorry about that. Go ahead, Justin. Tell us a little bit about yourself. Thank you.
Sure. So hi guys, my name is Dr. Justin Oveyssi. I'm a renal transplant fellow at Cedars-Sinai Medical Center over in Los Angeles, California. I just want to start off by saying that, thank you for having me on the stream. It's really inspiring to hear all of your stories and hear that you all are doing very well after kidney transplant, or a loved one that you've had who's had a kidney transplant is doing well. So I kind of want to expand a little bit on what Dr. Vohra just talked about regarding FSGS. I have a PowerPoint presentation that I'd like to share with you guys. So I'm going to try and share my screen here. Okay. Can you guys see my presentation?
Yes, we can.
Okay. All right. So, my rule is if we can understand something, you can help relieve some anxiety around that topic. So if I can help everyone kind of understand what FSGS is and why it happens, maybe we can help people, one, identify the problem when it does occur, and two, to be able to deal with some of the anxiety surrounding it. So I want to start off by saying that it's not a very common disease. It's a rare disease, but it does affect people, as you all know. It is one of the most common cause of what we call nephrotic syndrome in patients who have kidney disease. Nephrotic syndrome is a fancy term that essentially means you're having large amounts of protein that's spilling over into the urine, specifically more than 3 grams in 24 hours. That's what we use in medicine. So we have two kidneys, just starting with the basics. The function of the kidney is essentially to filter your blood and waste products. And if you can think of a kidney as a bunch of kidney cells, there's the nephron, kind of the functional factory of the kidney, where blood flows in through the glomerulus, through little capillaries, which are little blood vessels called the glomerulus, and the blood is filtered out through this structure here. And what we're going to focus on is that area that's called the glomerulus that Dr. Vohra was talking about, and that's the red area you see there with the arrow pointing at it. And that's what we're going to talk about when we're talking about FSGS, because that's where the damage happens. So the glomerulus is that part of the kidney, is the basic filtering system of the kidney. It consists of some blood vessels that flow in and flow out, and then it's surrounded by this structure called the Bowman's capsule. The Bowman's capsule is where the kidney, all the solutes are filtered across. So if you can think of those capillaries as bringing blood into the system, they're getting filtered across this Bowman's capsule into the kidney and then out into the urine. So this is where FSGS hits the heart. It's a disease primarily of that glomerulus, which is the site of filtration. And then you have the podocytes, which are the cells that are lining the Bowman's capsule that I mentioned. And it's these podocytes that are becoming scarred in FSGS. As you guys recall, FSGS stands for focal segmental glomerular sclerosis. So sclerosis means scar, glomeruli, or just the glomerulus, and focal means certain regions. So you have certain regions of the glomerulus that are getting scarred, and they're happening in certain parts of the kidney. And that's what FSGS is. So, what does FSGS do? I mean, it causes scarring, but the way it harms the kidney is that it causes protein to be leaked out, and specifically large amounts of protein. And we know that when protein starts to leak into the urine, these are one of the first signs we see of kidney disease. And so this filtering system is damaged. You have protein leaking into the urine, and then you have a lot of the symptoms that are associated with losing protein. So you getting that scar formation over time in certain parts of the glomerulus, and this is kind of what a cartoon looks like of that process happening. And this is what the normal glomerulus looks like on histology, which is essentially a biopsy of the kidney, and what it looks like under a microscope. And this is what it looks like when you have scar. So you see those arrows, that pink substance that it's pointing to. That's the area of scarring happening. And this is all that green stuff at the bottom of this microscope finding. That's all scar. So this is what FSGS looks like, and this is how it damages the kidney. So FSGS, as I mentioned, is a rare disease. It affects only about 7 people out of 1 million in the general population. But out of the people who have what we call nephrotic syndrome, which is kidney disease leading to leakage of protein into the urine, FSGS is responsible for about 40% of those cases. And in children who have nephrotic syndrome, it's about 20% of those patients. But all in all, FSGS accounts for only about 2% of all causes of kidney failure. And we know through studies that African Americans have 4 times the likelihood of developing FSGS, and men are 2 times as likely as women to develop FSGS as well. There are different types of FSGS that we touched upon there, and these are really critical to knowing how to treat and what to screen for. So we have primary FSGS, we have secondary FSGS, we have genetic forms of FSGS. And the way that we make this diagnosis is a little bit involved, but the gold standard is essentially to do a kidney biopsy first and foremost, and then combine the findings that we see on histology with the clinical picture. Are they obese? Do they have certain viruses such as HIV? Is there something else that could be causing secondary FSGS? So for us to be able to diagnose what type of FSGS you actually have is actually very critical to being able to treat you and preventing progression of kidney disease. So primary FSGS is the first one we're going to talk about. We don't know a lot about primary FSGS. It's hard to say what exactly causes it. We have a strong suspicion that it's related to your immune system, causing damage to the glomeruli. There are certain circulating factors in the blood that can damage the podocytes. It's essentially thought to be autoimmune. And it usually presents with a lot of protein in the urine. So by a lot, I mean nephrotic range, which medically means essentially more than 3.5 grams of protein in 24 hours. The way that we treat primary FSGS is that once we have a diagnosis, we start you on steroids. And sometimes steroids don't work and we have to use other medications that also suppress the immune system so that we can control the leakage of protein and potentially diminish it. Then we have a different type of FSGS called secondary FSGS. So this is the type that we have a little bit more control over if we can identify the cause. We know that there are certain drugs, certain medications that can predispose people to FSGS. We know that obesity is a big one, it is the major cause of secondary FSGS in the American population. Obesity, the way it can damage glomeruli is that essentially causes a lot of pressure to build up in the glomerular system. So you get something that we call hyperfiltration injury. And this hyperfiltration injury can scar the glomeruli and lead to secondary FSGS on biopsy. And then we know that there are certain viruses that we screen for when somebody's been diagnosed with FSGS, like HIV, for example, that if we can control and if we can treat, we can potentially get the protein level down and treat somebody and bring them into remission for secondary FSGS. And so there's a last category that we haven't really discussed much, which is genetic FSGS. Genetic FSGS is a tricky one. It may or may not show some inheritance patterns in the family. You might have a mother or father or uncle or somebody who has it, and that might clue us into doing genetic studies to see if you have genetic FSGS. But it typically presents either very early in life or later in life, but commonly very early in infancy. And usually these patients, they have an early onset of hypertension, so they might start developing high blood pressure at a very early age. This form of FSGS is not as amenable to treatment as primary FSGS is. So you might have a case where the child is being treated with steroids and other types of medications, immunosuppressive medications, but they're not responding and they're continuing to spill 3 grams, 3.5 grams of protein into the urine. They're still having the swelling. They're still having the swelling around the eyes, around the shins. And there's some studies that have shown an association between the APOL1 gene variation, which is a type of gene that we look at when we're looking at risks for developing membranous and glomerular diseases. And there might be a link between this particular gene, along with many others, to genetic forms of FSGS. So this is kind of the algorithm that we as clinicians follow in order to make the diagnosis of FSGS. First off, we start off by biopsy. So when we have a patient who tells us, hey, I'm having urine that's foamy, I'm having a lot of swelling around my eyes, around my shins, I'm feeling like I'm getting a lot of water weight, we start by doing a urine study. And we check to see how much protein they're actually spilling into the urine. And if they meet that definition of nephrotic syndrome or proteinuria or protein in the urine more than 3.5 grams, then we proceed to biopsy, because now this is putting us into something being wrong with the glomerulus. We look at the glomerulus and we look at how much scarring we're actually seeing, how much foot process, which is those podocytes that are part of the Bowman's capsule that I mentioned earlier, how much scarring are we actually seeing on that microscope? And if we're seeing a lot of scarring, by a lot I mean more than 80%, we try to give them some immunosuppressive medications, thinking that this might be a primary FSGS, and it might respond to medication, it might respond to immunosuppression. And if it does, then there we have it. We have a primary FSGS diagnosis. It's responsive to therapy, and hopefully we'll keep the disease quiescent, and the patient will continue in remission. And if it comes back, get them with immunosuppression again. But if it doesn't, then we have to look at other causes of FSGS. Is the patient obese? Do they have a high BMI? Are they taking certain medications or certain types of drugs that could be causing them to develop this type of lesion on their biopsy? So we look for other reasons, and if we can figure out those particular causes and treat those, then we can potentially help prevent the progression of their kidney disease. And then if that doesn't work, and we can't find anything, then we think of genetic studies, and we look at the family history. We ask the patient, do they have somebody in their family who had dialysis? Do they have somebody who had early kidney disease or early hypertension? So we start doing some genetic tests to see if there could be a genetic component to this FSGS. I can say that as a transplant fellow, that the patients who have primary FSGS, they tend to have more recurrence after kidney transplant. So listening to Shannon's story and some of the stories that I heard today, I think that it's likely that I can't say for certain, but it's likely that he had primary FSGS because there was recurrence after transplant. The genetic and secondary FSGS are less likely to recur after transplant. Secondary FSGS, if you can identify the cause for their kidney disease and treat it, then the likelihood of them having recurrence after transplant is a lot lower than in primary. So you can see how challenging primary FSGS can be, because it can be transplanted 2 or 3 times and still have recurrence, and there are different medications we can try to use to help sustain remission, but a lot of the times there's recurrence and it's expected. So as I mentioned, some of the symptoms from a patient perspective to look out for, if you have a family history of kidney disease or you yourself have kidney disease, and you're being vigilant, is if you start developing some swelling in your ankles and feet or around your eyes, if you start noticing some foamy urine, and by foamy I mean not a few bubbles here and there. I'm talking about what you would associate with body wash bathtub would look like, foamy. So if you start seeing that, you start noticing that you're more fatigued, you're having loss of appetite, you're having higher blood pressure than you normally do, you're gaining a lot of water weight, your cholesterol levels are high, or you're forming new blood clots, I think that is a good indication that you should let your primary care doctor know, and they can do some further tests to see if you are leaking some protein in the urine. And if you are leaking protein in the urine, the next step that a primary care doctor can do is refer you to a nephrologist. And the nephrologist can do further tests to see why this may be the case, or even send you for a kidney biopsy if he's concerned. So the overall prognosis of FSGS largely depends on the type of FSGS you have. If you don't treat FSGS, a large majority of them actually progress to end-stage kidney disease. So patients who have a lot of protein, as in the nephrotic range over 3.5 grams, they have a progression rate of about 50% to end-stage kidney disease after 10 years. And only 15% of patients who have less amount of protein or subnephrotic protein progress to end-stage kidney disease at 10 years. And how you respond to therapy largely determines long-term outcomes. So those who have complete response tend to do better over time and have less instances of recurrence than those who don't respond to therapy. So how can we stay healthy? With any disease process, going to the doctor regularly, doing your yearly blood work and urine studies is really key. Maintaining a healthy diet and weight, not developing obesity, maintaining a low salt, low fat diet. And then if you start to notice anything, symptom-wise, or if you know that you have a family history of kidney disease, this is a very important thing to let your doctors know, so that they can do tests and check you for kidney disease. And as always, avoid this use of illicit drugs and practice safe habits. So if you have symptoms, let your doctor know early, and the earlier that your doctor is informed of your symptoms, the earlier he can test you, and the quicker they can start you on treatment if you have a diagnosis of FSGS, which would overall, improve your chances of having remission if you have FSGS, or preventing progression of your kidney disease. And if you do progress, then you have the option of talking to a nephrologist about dialysis or transplantation early on. I'm going to stop here.
All right. We have any questions?
Yes, that was a great great example of what FSGS is, man. Thank you so much, Dr. Oveyssi. One question I have for you is, how can you tell when it's genetic?
So there are some things that can tip us off, such as if you have a father or mother or grandfather or uncle or somebody who's related to you that had kidney disease early on in life. That's usually the first tip off. But a lot of times we don't know unless we actually do the testing and we check for certain gene variations that we know are commonly associated with FSGS. So there's a genetic panel that we can send the patients out for, and those genes, those particular genes, can clue us into whether or not somebody actually has a genetic form or has a genetic tendency. But it largely starts by asking if you have any family history or somebody within your immediate family, first degree, second degree relatives who have had kidney disease or have had some suspicious early onset hypertension early on in their life. That would be really close to them screening for genetic causes.
And another question I have for you is, will it continue to come back into transplanted kidney? Because that's what I'm seeing right now, what I'm going through. Like my first transplanted kidney, it came back, and now the second one I have right now is coming back. So.
Right. So like I was mentioning, I mean, it depends on the type of FSGS you have. Primary FSGS is most likely to recur. Secondary and genetic are not as likely to recur after transplantation. Your case, it's difficult, and it's a challenge dealing with recurrence, and we see it quite a bit. It's hard to say whether or not you will or will not recur, but there are treatments that we can give you that suppress your immune system after transplant. And even at Cedars-Sinai, we actually, if we have the inkling that somebody might have primary FSGS, we actually give them certain immunosuppression, certain IV infusions right before the transplant to try to lessen the risk of them developing recurrence of their FSGS after transplant. So, it's hard to say exactly whether you will or will not recur, but the more recurrences you have had, the more likely you are to recur in the future. And but there are treatments that we can offer to try to prevent those recurrences from happening.
So even if I was to get another transplant, it still will come back. Do you think it's a good chance it still can come back?
I think the fact that you've had 2 recurrences says that you are susceptible to having recurrence again if you do have another transplant. But that being said, I can't say for certain if you're going to recur or not. It's difficult to say because some people don't recur, some people do. But statistically, the more recurrences you've had, the more likely you are to have another recurrence after a transplant.
Right, because before my second transplant, I had over 56 treatments of plasmapheresis. So I understand what Shannon, what she was talking about with plasmapheresis. It was harrowing. My day went plasmapheresis, then dialysis, then they would give me a protein called cytogam. I know you're pretty familiar with that also. So, and that went for a long time like that. But okay, any other questions from anybody else?
Yeah, I got one question. We talked about one of the counteractions is immune suppressant drugs for, and my question is, like, for me, I'm already, I have a kidney transplant and I'm on immune suppressant drugs. So if, say, like with Brother Tafaro, are there more suppressant drugs that maybe he's not on, or will you guys like up the dosage of what he's already on as an immune suppressant drug?
So that's a really good question. No, and that's what we think about. People who have transplants, they're on medications already to suppress their immune system. They're usually on a steroid. They're usually on what we call a calcineurin inhibitor, which is essentially tacrolimus or a cyclosporin. And then they're on a third different medication, usually called either Cellcet, mycophenolate, something along those lines. So they're usually on the 3-drug regimen. But despite that, they may still have recurrences. They still have an immune system that's causing them to have recurrence and have sclerosis of glomeruli and develop protein leak. So there are different types of immunosuppressive infusion therapies, which are usually IV therapies that we can offer to patients, and I'm sure Shannon can speak to that. Flex is not a medication. It's essentially a form of taking the blood and removing the antibodies from the bloodstream so that those antibodies don't attack the thought processes to prevent your immune system from causing damage to the glomerulus. But there are other medications as well that help deplete antibodies from B cells. So higher level immunosuppressive IV medications that we can offer patients who have recurrence. So usually we don't tinker too much with the essential immunosuppressions that people are on for rejection, but we do offer them other forms of IV therapies and treatments to prevent their immune system from attacking and causing them damage.
Okay.
A quick question again.
Okay, go ahead.
Hi, my name is Alana Honeycutt Carroll, Chef Alana, 2-time kidney transplant recipient, and I've had FSGS for over 28 years now. Is it so? FSGS, is it just like the overall scarring of the kidneys? Because when I hear it comes back, I hear that if it's going to come back in a transplanted kidney, it comes back early on. However, my first kidney lasted 10 years, and then they said the FSGS came back. I'm a little suspicious about that because I feel like maybe the medication scarred my kidneys opposed to the FSGS coming back. So is that a possibility?
Alana, it's not the medication. Most of the time, your kidney functions can decline after you get a kidney transplant. And there may be some protein leakage in the urine that may not be FSGS. So your nephrologist will tell you, like if the leakage is minimal protein, that does not necessarily means FSGS. You can also measure one particular marker in the blood, which is a marker of FSGS, flare or worsening. So it not necessarily, like the medications. The medications, immunosuppressants, can do some other damage to the kidney, and Dr. Justin is going to tell you, like it can affect the kidney in other way, but it does not cause FSGS as such. With all the medications patients take, we also tell the patients, to make sure the diabetes is very well controlled. Like in your case, it may not be, because that's another reason you can leak the protein, right? The blood pressure should be very well controlled. The diet should still be the low salt. All the other measures to be looked for, and when the protein leakage starts happening, we have to make sure that leakage is FSGS. So either they check with a marker or they check with a repeat kidney biopsy of the transplanted kidney if you reach that level of protein leakage.
Okay. And my other question is, I've been on Cellcet for both of my transplants. Why do they choose Cellcet opposed to Belicep? Is there a reason why they choose one over the other?
Are you referring to belatacept?
Belatacept, if that's how you pronounce it. Yeah.
Belatacept. So belatacept is usually not a substitute for Cellcept. So Cellcept is kind of considered the first-line immunosuppressive therapy for at least one of the 3 major immunosuppressive therapies that we use in kidney transplant patients. It's under a category called anti-metabolite. So usually patients who have had kidney transplants are on either a Cellcept or a Myfortic. Both of them are kind of under the same category of medication. Belatacept is another type of medication that we can use if patients start to develop damage due to calcineurin inhibitors, which is that program that you're referring to. And as Dr. Vohra is mentioning, program itself can sometimes cause injury to the kidney and can cause chronic changes in the kidney itself that cause progression of the disease. So if we start to see that, we do a kidney biopsy and we see that those types of changes are happening in the kidney, we can consider switching somebody off of Prograf to belatacept. The belatacept is essentially a monthly IV infusion that we would give you as a substitute to the Prograf that you're taking. but it is not proven to be effective as a substitute for CellCept. CellCept is usually is the standard of care medication that we give kidney transplant patients.
Okay.
And actually, the CellCept is the safer for the kidney than calcium inhibitors or the Prograf, which can have some long-term consequences using to the kidney, just like Dr. Justin said. The CellCept causes other side effects, diarrhea, white count drop, and GI disturbances, but not necessarily the kidney damage as such.
Yeah, right now I'm on mycophenolic acid, prednisone, and what's the other? Tacrolimus. Yeah. Thank you.
Fred, I have something I'd like to jump in if it's time, or I can wait until, however we're going to do this as far as speaking.
Okay, you have a question? Because I know we're going to have. Okay,
I do.
go
ahead.
Go ahead.
Yeah. So it was kind of on the lines of what Alana was. I'm sorry. Everybody that doesn't know me, I'm Bella Langston. I had a kidney transplant in 2005. I was actually diagnosed with FSGS right off my probationary status as a Chicago police officer back in 1994. And I've now had my transplant for 18 years. Fortunately, I've never had any problems. It's a blessing. And I was just thinking about what she was saying as far as the medications. I loved your presentation, Dr. Oveyssi. And, one thing I have experienced as a long-term kidney transplant recipient and the extensive research that I've always done on FSGS and being a part of the hospitals as a PFAC advisor, the medications can definitely seem to cause long-term side effects in many ways. I know for me, I ended up with hyperparathyroid disease about 5 years ago. So it ended up that it showed up as through a cystomebi scan and at tumor on adenoma, as it's mostly described, on one of my parathyroid glands. I ended up getting a procedure, amazing hospital when I was living in Florida, Norman Parathyroid Center. People come from all over the world to go there. And he checked and there were actually 2 more. So we have 4 parathyroids. And so I had 3 adenomas, which were all, thank God, non-cancerous and removed. But the possibility that it was due to, the medication, I was told was pretty great, as well as 4 years ago getting diagnosed with type 2 diabetes. And so, I know, Dr. Vohra, you mentioned about weight and things like that. And I do always feel that that's a factor. But do you also feel that obviously there's going to be sometimes people that are going to be exceptions to that rule? I know I was always in pretty much great physical shape and athletic. And on the medication, as Alana was saying, initially on my transplant, I was put on CellCept and Prograf. I never took the prednisone. I refused it, and they never put me on it, so I never had it. So that to me was a blessing. But I switched over probably it's been 2.5 years ago to Invarsus XR. I like the fact that I only had to take it once a day. And so far it's been working well. So that's kind of like my question in there. Are those type of exchanges possible for more people? And do you feel that oftentimes the things that I described can be due to the medication, to long-term on it long-term?
Sure. Bella, long-term exposure or taking Prograf predisposes you for certain diseases. Diabetes is one. We know that, the patients develop the type 2 diabetes. They also can develop some skin changes, Justin is going to elaborate later. But yes, these medication comes with a risk, but, the benefit that you're off dialysis and then your kidney stays healthy for 20 years. First of all, congrats, 18 years, you're staying healthy. I'm very happy for you.
Thank you.
And yes, it does come with a risk. It does come with the side effects of developing diabetes. And that's why we tell the patients to have a regular follow-up with a nephrologist or a transplant kidney specialist, and get your A1C checked, your sugar level checked. And then since the risk with the medication is there, you don't want to add on the second risk. And I'm very happy when you said you're very athletic, because we want to promote patients to do more exercise, do not gain weight, and stay away from all the risk factors associated with the diabetes, because we know that the medication is going to give it to you, because the medication comes with a known risk of this. So.
Yeah, so
Thank you.
I want to also congratulate you. 18 years, that's excellent.
Thank you.
I hope that you'll never need another kidney transplant.
I do too. And that was a living donation, by the way.
Wow.
Yeah.
Good. That's amazing. No, it is. You're very correct in saying that there are side effects to all of these medications, right? I mean, prednisone classically is known to increase your weight, increase your blood pressure, increase your blood sugar. These calcineurin inhibitors like Prograf, they can cause hair loss. They can cause, diabetes. They can cause your blood sugar to go up as well. Prednisone causes weight gain. So they are that's for sure. But we want to be very careful with taking away these medications or changing them too early, because we know that patients, when we do that to certain patients, they are higher risk for rejection. And rejection ultimately leads to graft loss. Graft loss leads to recurrence of needing dialysis and, again, being back on dialysis. So we know that being dialysis is long-term is not good for your overall health than having a kidney in most instances. So there's a balancing act. And as Dr. Vohra mentioned, it's very important to follow up regularly and do blood tests, make sure your A1C, your diabetes is under control. If you develop diabetes, there are patients who end up on insulin after transplant when they weren't on insulin before, because their body needs insulin to now control their blood sugar. So there's a phenomenon called new onset diabetes after transplant, or diabetes after kidney transplant, which is a known phenomenon. So yes, I absolutely agree that and know that there are side effects to these medications. And sometimes you have to take an individualized approach to people. You can't treat every patient. There are patients who are high risk to reject their kidneys, and there are patients who are lower risk for rejecting their kidneys. And for those that are lower risk for rejecting kidneys or further out from transplant, because the further out you are from transplant, the less likely you are to reject, we'll have a little bit more flexibility to maybe change some of those medications around to prevent some of the unwanted side effects. But during the immediate post-transplant period, we have to be very careful, because we don't want to cause you to reject the kidney in an attempt to prevent you from developing diabetes. We don't want you to develop diabetes, but we don't want you to reject the kidney either, and we don't want you to go back on dialysis. So that's kind of the challenge that we as transplant nephrologists have to deal with our patients.
Thank you so much.
I have one more question on this topic. Is when we talk about FSGS, is this disease the number one disease that is having people get 2 or 3 transplants, or do we see that in any other diseases that affect the kidneys?
Sure. The most common disease in America still remains the diabetes related. Around like 50% of the patients in America gets a kidney failure because of the diabetes and obesity and hypertension, mainly diabetic kidney disease. So those patients are again, getting into the kidney transplant. The diabetes or lifestyle does not get better, or the compliance on the medication does not stay the same. So the patient does not take the medications as prescribed, or develops the diabetes after the kidney transplant, or hypertension. So the rejections, I don't think the only FSGS is causing the second transplant, or it's not the most common cause for the second kidney transplant. The most common disease, affecting the kidney still remains the diabetes. These are the rare causes.
Go ahead. I'm sorry. Go ahead.
No, that's what I'm saying. These are known causes of having the recurrence, but it still is a low prevalence in the community, or low prevalence in the population.
Okay.
Right.
Okay. Thank you. Thank you, sir.
I got one last question. It's okay, Tafaro. for me, well, I think Chef Alana. She said that she's been dealing with this. Did you say over 20 years? I think she said over 20 years. Um, and the question I have, because I work with right now with Aleo, VentureMed, Flex. These are companies now that are being more involved in kidney disease. And one thing that they have now is coming up is remote patient monitoring, monitoring blood pressure, blood sugar, phosphorus, hemoglobin, potassium, and other things. And my question is there anything that's on the horizon, whether it be technology, procedures, medications, that's on the horizon to help the patients with FSGS? Is there anything new or anything that's
yes. There is a serum marker or a marker of protein, abnormal protein. It's called SUPAR, SUPAR. It's not diagnostic of FSGS specifically, but like we can monitor the increase in the immunity or worsening of the disease to the level, or once we suppress the immunity, the level goes down. This is a blood marker, but that does not replace the kidney biopsy.
Okay.
About the remote patient monitoring, I am in a total believer of that. So I believe the healthcare delivered at patient's home is the best healthcare. So remote patient monitoring of the blood pressure, the diabetes, the diet education, and the lifestyle modification. But in terms of monitoring the disease progression, we have some markers, which we can look into, and doing. I'm not sure, how frequently your nephrologist is doing, but I believe a frequent check of urine protein creatinine ratio. You don't need to do 24-hour analysis of urine. You can do a spot analysis, like some sample of urine. You can give it to the nephrologist. He checks how much protein, and he does the rough calculation. How much protein you're leaking in a day, and that's the first alarming sign. So, like, there are some blood markers, but frequent checkup and the remote patient monitoring is very important. It's an important aspect of the healthcare delivery, or a better healthcare delivery.
Okay. Well, that's exciting. Any other questions? All right, we get ready to move. Got one commercial coming up from the Why Not Foundation, and then Tafaro will be introducing Lindsay Ducharme. All right, here we go.
Hey, what is going on, world? Edward, Mr. Why Not Drink is here. I wanted to hop on here to invite all my Southern California peeps out to the Why Not Foundation Bowling for Causes event on May 13th from 5 to 8 p.m. at Bolero Bowling Alley in Westchester, California. I'm so excited. As you can see, I'm based out of our Atlanta, Georgia office, but I'm excited to get out there and impact lives with the rest of my teammates. Of course, why not? We've been doing a lot of work out in the California area, dropping off school supplies and gifts at both Children's Hospital of Los Angeles and UCLA Mattel, amongst several others. And yeah, just wanted to get out there and impact some lives out there. So please come out and have a great time for a great cause. Why not? Salute to the Second Chance for this amazing opportunity to promote this event, and God bless you on your conference. Mr. Why Not out.
Awesome. Good job, Edward, my man. So now we're going to introduce, Lindsay Ducharme. Lindsay, tell us a little something about yourself.
Hi, so thanks for having me. So I am a kidney dietitian. I've worked in dialysis for 8 years, and I had switched to working with patients with CKD who aren't on dialysis in 2021. And I recently went full-time into that. So I have a private practice, and it's called Vital Kidney Nutrition. And I just love working with people with kidney disease and helping them slow the progression of their disease and improve their quality of life through nutrition. So I do have a presentation I'm going to share. Can you see my screen?
Yes.
There we go. Okay, so I'm going to be talking about nutrition management of proteinuria in FSGS. So just a brief outline. I'm briefly going to discuss what is FSGS, although the doctor's already touched on this a lot. We're going to talk about some nutrition areas of focus for improving proteinuria. And I always like to talk about the foods we want to encourage, because it's more than just limiting foods. We want to be encouraging the healthy foods, and we want to know, what can we eat? So here's just a picture of inside the kidney. So this is the glomerulus. So this is the part of the kidney affected in FSGS. So specifically, there are cells in the glomerulus, the podocyte cells, and these cells are damaged. And the podocyte cells, when they're damaged, that's how the protein leaks into the urine. So FSGS can cause nephrotic syndrome, which can be very difficult to treat. Symptoms of nephrotic syndrome include swelling, protein in the urine, people develop high cholesterol, and some of the basic treatments include medications, steroids, immunosuppressive drugs, but diet can be used to support the treatment as well. So I really wanted to address proteinuria, because proteinuria, the more proteinuria you have, the more at risk you are for your kidney disease to progress. And diet can help with the management of proteinuria, and anything we can do to help, the better. So these are some areas of diet I'm going to touch upon. So we're going to talk about low sodium diets briefly. We're going to talk about limiting animal protein and a gluten-free and dairy-free diet, which is not really talked about a whole lot, but there is some research and case studies where this has been effective, specifically in FSGS and other nephrotic syndromes. So sodium-wise, most people that are dealing with proteinuria, you want to limit your sodium to less than 2,000 milligrams a day. So it's not just about taking away the salt shaker. Most sodium in our diet is what is already in our foods. It's going to be in the packaged foods. It's going to be in outside foods, like at restaurants. So not just fast food. It could be, a sit-down restaurant. People tend to think, they're sitting in a restaurant, so it's healthier, but not necessarily is it going to be low in sodium. And, you want to watch your food labels. So I have these 6 foods here, because these are known as the salty 6, according to the CDC. These are the 6 foods where most Americans are getting the majority of their sodium from. So breads and rolls, pizza, sandwiches, burritos and tacos, soup, and processed meats like deli meats, bacon, sausage. So these are foods you definitely want to cut back on to limit your sodium. So it's really important to be reading food labels when you're shopping, because you would be surprised. Even foods that do not taste salty could be loaded with sodium, like a lot of breakfast cereals. They have a good amount of salt in them. Even, things like pastries, sweet tasting things, there can be a lot of sodium hidden in those as well. So when you're looking at your food label, I always tell people, start with the serving size, because just because a food item looks like it's meant to be 1 serving, it may not necessarily be. So all of the nutrients are going to be based on the serving size. So say it's like 10 crackers. So if you're eating 20 crackers, you're getting double the sodium. So it's important to know the serving size first. In general, a low sodium food would be a food that has 140 milligrams of sodium or less. So when it comes to figuring out how much sodium one can have at a meal or a snack, some general guidelines are maybe less than 500 to 700 milligrams of sodium, and for snacks, less than 150 to 200. So this is kind of a wide range. But, if you're someone, and it really depends on how frequently you're eating, but say you're having, you eat 3 meals a day. So if you're doing 500 milligrams of sodium per meal, that's 1,500 milligrams. So that's still within your restriction. And of course, some meals, like, breakfast and lunch, maybe you're only having 200 milligrams of sodium. So you may have a little bit more wiggle room, say, like, you are going out to, a birthday or something, and it's going to be harder to control the sodium. So you can have a little bit of flexibility that way. So in terms of protein, excess animal protein can worsen proteinuria. So animal protein has been shown to increase the pressure in the kidneys, which is why it can cause the kidneys to leak protein. So people with FSGS, they may have low albumin levels. So albumin is a protein in the blood. And some people may think, oh, I have like a low albumin, I have low protein, so I need to load up on my protein. But that is not going to fix the situation. It could be worsening it. So protein is also found in plant foods, and having more plant proteins in your diet is associated with less proteinuria. And there are some studies that even particular plant proteins like soy protein may be kidney protective, possibly due to the isoflavones, which are special plant chemicals it has. So let's look at different types of protein. So when we're thinking of animal protein, we're thinking of anything that comes from a living creature. So it can be poultry, so chicken and turkey, beef, pork, seafood, fish, eggs, dairy that's coming from an animal. And plant proteins, on the other hand, are foods that you're going to find grown in nature. So things like beans, lentils, peas, nuts and seeds, nut butters, soy products like tofu, edamame. So let's talk about gluten in dairy. So there are several studies out there, not necessarily specific to FSGS, but they have shown that gluten in dairy-free diets can help to manage nephrotic syndrome. So, and specifically help with proteinuria. So the mechanism is still unclear, but there are a few hypotheses. So it has to do with food sensitivity. So if someone has a food sensitivity, especially to gluten and dairy, it can produce an immune response that can possibly damage the podocytes. So that's one hypothesis. So in people who are gluten sensitive, so gluten is a protein in wheat. So consuming wheat, if you're gluten sensitive, can cause a rise in a substance called zonulin. So zonulin then is a chemical that relaxes the junctions of our GI tract. So our GI tract is supposed to be very tight because it's kind of protecting our body from, potential toxins, like things that we eat, it's going to go through our body, and then our GI tract is going to be the barrier. So substances that aren't supposed to be in our blood don't get in there. But with zonulin, it actually relaxes the junctions. So substances that shouldn't be in our blood get in there. So especially, some of these materials could be toxic. So that is another theory. And another hypothesis is zonulin has been shown to have a negative impact on the podocyte cells. So zonulin itself may impact the podocyte cells. And they've actually shown this in mice studies, which is, completely different than human, but I found that interesting. So in terms of dairy, so the protein in milk, so there's two proteins, whey and casein, but casein in particular can trigger inflammation in some people, especially, people with celiac disease, so they can't have gluten. They can often be sensitive to dairy as well, just because the structure of casein is similar to gluten in structure. So I wanted to touch upon a research paper published in 2021 titled Immunological Impact of a Gluten-Free, Dairy-Free Diet in Children with Kidney Disease. So this was a proof of concept study, which they looked at the feasibility of, running a larger type of the study, and they wanted to look at the safety of the dietary intervention. And long story short, it ended up, being very safe and well tolerated. But the synopsis of the study, so it was very small. They had 16 participants. They ranged from ages 2 to 12. They all had steroid-resistant nephrotic syndrome due to either FSGS or minimal change disease, which is similar to FSGS. And they were put on a gluten-free, dairy-free, low-sodium diet for 8 weeks. So from the results, they did have some positive results. It said we showed that a gluten-free, dairy-free diet had a major anti-inflammatory effect in all participants. And they showed a 4-fold increase in T regulator and T helper 17 cells ratio. And there was a favorable impact on their gut health. So 2 participants out of the 16 or 17 patients had achieved complete remission. So in these 2 participants, at the beginning of the study, they had high zonulin levels. So this is something that they're looking at, the zonulin levels, to see if people, could potentially respond to this kind of diet. So I really think it may be worth trialing a well-planned gluten-free, dairy-free diet in those with FSGS. So let's talk about what that would entail. So when you're avoiding gluten, so anything that has wheat and different varieties of wheat. So it's, when you think of gluten, you're going to find it in regular breads, anything that's a baked good, pastas, crackers. So I've listed, all these foods that you could find gluten. It could also be hidden in certain things like sauces. Some sauces, have flour in them, or gravies, soy sauce, and communion wafers. So when you're looking at a food label, there is a lot of things that you kind of have to look out for. And on a dairy-free diet, so it's not simply just choosing lactose-free milk, because lactose-free milk, it still has the milk proteins, which is the problem. So anything with milk, butter, cheese, and again, the dairy could be hidden in baked goods, because a lot of times you're using milk in like a cake or something. And dairy could even be hidden in processed meats. And these are some other ingredients that are a little bit tricky. It's not obvious, but these are other ingredients that could mean the food has dairy. So some kind of tips you can use on a gluten-free, dairy-free diet. So not all foods have this certification if they're vegan, but if a food is vegan, if it's certified vegan, there will not be any animal products. So that includes dairy. And you'll see this a lot. A lot of foods are choosing to do the certified gluten-free. So you can be sure that you're getting a product that's not contaminated. But there are lots of foods that are going to be naturally free of gluten and dairy, which tend to be the foods you want to be focusing your diet on anyways when you have kidney disease. So these are things like fruits, vegetables, proteins like beans and legumes, soy, tofu, nuts and seeds, fresh meats, poultry and seafood. You want to do fresh rather than processed. And as we talked about the animal protein prior, you want to limit the portions of these foods. So there are plenty of grains and starches that are going to be naturally gluten-free. Things like rice, quinoa. There's so many gluten-free pastas on the market. They have pasta made from, chickpeas, lentils, and then there's the standard gluten-free pasta that's typically like corn or quinoa based or rice based. There's lots of gluten-free bread options these days. When you're doing oats, you do want to look for certified gluten-free, because oats themselves don't have gluten, but they're often prepared in a facility where gluten is. So there could be some cross-contamination. Potatoes, of course, are gluten-free starch. And for other items that would be allowed, dairy-free yogurt. Again, lots of plant-based dairy items these days, which is nice. Things like olive oil, avocado oil. And there are plenty of snack companies that are specifically free of allergens. So that usually includes gluten and dairy and a few other allergens. But these are some brands, the Lara bars, Enjoy Life products, Made Good products. These are definitely gluten and dairy free. And, things like tortilla chips, most store brands are going to be gluten free. They're just made of corn and maybe a little bit of salt and oil. So in summary, diet can help play a role in managing proteinuria for FSGS. Key strategies include limiting sodium and animal protein. Gluten-free and dairy-free diets may be another strategy. There is definitely more research needed to examine the connection of gluten and dairy and FSGS. But in my opinion, trialing a gluten-free and dairy-free diet definitely could cause no harm, and it could potentially give someone really good benefits. So why not try it, especially under the supervision of a dietitian? All right. And if anyone has any questions, feel free to reach out to me on Facebook or Instagram, and feel free to check out my website. Okay.
All right. Somone has a question for you.
Mm-hmm. Yes. Hi, my name is Somone Washington. I have had a kidney transplant for a little over 12 years now. And my encounter with FSGS was slightly different than the stories we've heard on the conference so far. My bout with FSGS happened after I was diagnosed with end-stage renal failure and before getting the transplant. And I just experienced a lot of joint pain to the point where I became immobile for hours on end. It was excruciating pain. But after transplantation, I didn't have any other symptoms. And when I was diagnosed, the doctor said that they weren't sure what caused my kidney failure, but they did recognize that they discovered FSGS at the same time, but they weren't confident in saying that that is what caused my kidney failure. So my question to you is, with that kind of diagnosis, like, how would you advise me to decide, like, should I maintain the advice and the diet that you're suggesting, or should I be on a different diet for kidney patients? And then my second question is, a lot of the foods that you're suggesting that we replace with, like the beans and lentils and things, are high in potassium, and that's another thing that we have to pay attention to and watch out for, so that our potassium levels aren't high, because that causes another set of issues for us. And so, like, it has always been a struggle for me to balance that, especially doing things like participating in Daniel's fast or different fasts that's just fruits and vegetables. At the end of it, the potassium levels are usually off the charts, and my doctors are like, my nephrologist is like, what have you been doing? You know, you can't do whatever that was that you were doing. So what is your suggestion in all of those aspects?
Yeah, great questions. So diet is definitely very individual, person to person with CKD. And so, I mean, I haven't treated a lot of patients with FSGS because it's rare. So the patients that I have had, I did suggest trialing, especially mostly the gluten-free. And some people, they felt like it just wouldn't fit into their lifestyle. So, some people just aren't, that's just not, they feel like, I can't really do this right now. So, there's other things we can focus on. But I do have one person who is currently trialing it. So it would be interesting to see. But yeah, it's all about meeting the patient where they're at. And I think it's really important that people are still able to, enjoy some of the foods that, they like. So for one of my patients, she was like, bread is really part of the meal. Like, she has given up so much already. So she's like, I can't. And I'm like, I totally agree. And I think, that's fine. I'm not going to push something, because it's about, people's quality of life. So, I mean, but I think, for people who are open to it, it's worth trialing. So even if you trial it for a couple months, because I do have some people, with just nephrotic syndrome, lupus nephritis, who do respond pretty well to the gluten-free diet. Especially, they say it has helped with inflammation and, improving symptoms like brain fog. So I think it's worth a try if people are open to it. The potassium. So yes, this is a hot topic because they have shown, so I really practice a lot of more plant-focused diets. I say plant-focused because, I mean, so it's about, encouraging the plant foods. It's not necessarily putting people on a vegan diet. But in the research, they're showing plant-based diets, which are encouraging fruits and vegetables and legumes and beans. They're actually not associated with high potassium. And they think it's partially due to the fact potassium in plant foods, because of how it's packaged in the cell, we don't actually absorb 100% of it. Whereas, foods like meat and dairy, they're also going to be significant sources of potassium. So if you're replacing meat and dairy with beans, you're actually not getting more potassium. It's kind of equaling out, and you may actually have better potassium control, because with more fruits and vegetables, you're also more regular. So anytime with kidney disease, there's definitely a link with you're excreting more potassium in your bowels, they've shown. So the more times you're moving your bowels, you could potentially be maximizing the amount of potassium that you're excreting. So that's going to help the high potassium foods like the fruits and vegetables also help to counteract metabolic acidosis, which is another condition that's associated with high potassium. So plant-based diets, when you're doing them right, they may not necessarily be leading to high potassium, especially, when you're replacing, some of these animal products and the processed foods, especially, which can have the potassium additives. But I mean, you definitely, for people that have history of high potassium, you want to be cautious. Definitely want to stick to the low potassium fruits and vegetables. You want to stick to the beans and legumes that are lower in potassium, like things like chickpeas are one of the lower potassium plant proteins. So sticking to like peanut butter, like just the foods on the lower end, just to be safe. And then you can kind of, track your labs and see how you're doing. But I don't think you don't have to necessarily, most people are really worried about the potassium because of course it's scary. Like if your potassium's high, like you could have a heart attack. That's terrifying. But I don't think people need to be, especially people that don't have history of high potassium, they don't need to be as scared of the fruits and the vegetables and the beans and legumes and things like that.
Thank you.
You're welcome.
And to any of the other doctors that are on, like, do you have any thoughts on, because I'm not even sure I am an FSGS patient since I had like a brief bout with it after diagnosis and before transplantation. Like, what are your thoughts on that?
About the diet, the plant-based diet always works. So we are recommending that to slow down the progression of chronic kidney disease. And there is specific diet, just like Lindsay said. But we are a big believer. Like in more and more researches are showing that the plant-based diet works better, especially those who are in an advanced stage of kidney disease. And then you want to slow down the progression so that they don't end up on the dialysis faster. I think other than the medication, diet and lifestyle and more plant-based diet, it's highly recommended.
Yeah, I would agree with that. So a low protein diet, plant-based diet. And then in terms of medications, I always say to avoid anti-inflammatory medications. So if you have a history of chronic kidney disease, you want to avoid ibuprofen, all those medications, Advil that fall under the anti-inflammatory. On top of having a low protein diet, you want to be very careful to avoid those.
Thank you.
I have a question for Lindsay. Can you hear me?
I can.
Okay, great. It's a two-part, and one of them was just on what you were touching on and the doctors were touching on about plant-based diets. If you are going to adamantly seek a plant-based diet, is it wise to ensure that your vitamins are at the level where they should be, as well as minerals? Because that's what I'm always wondering. I like plant-based, but I'm always cognizant about my vitamin intake, because as a transplant recipient, like for instance myself, I am on a 50,000 BTU once a week vitamin D, because again, we're coming right back around to oftentimes when you're further out, post-transplant, your body, and as you get older, so I have to claim that too, being my age, our body starts to naturally deplete of certain vitamins and minerals. So, they have to pump that back up. Like I take magnesium. That's something that's really important for our bodies. So that's the first question with regard to vitamins and minerals in a consistent plant-based diet.
Yes, so that is a really good point. Because plant foods, they do lack certain nutrients, specifically B12. That's one vitamin you're not going to find. Actually, you'll find it in like a product called nutritional yeast, but it's found in animal products. So a plant-based diet has to be supplemented if you're going to be 100% plant-based for it to be effective. You could be, iron and calcium, vitamin D. Those are typical supplements, sometimes omega-3, because when people are doing a plant-based diet and not supplementing, they do have a risk of deficiencies, which is not going to help your situation at all. So you definitely have to be careful and, be supplementing appropriately when you're doing plant-based.
I was going to make this comment. I think the diet has a lot to do with the individual. It's more of an individual thing when it comes to the diet, because I do a lot of plant-based also, but I still do get, some chicken in every now and then and stuff like that. And it works for me. But I really think when it comes to the nutrition, it's an individual thing. That's the statement I want to say.
Yeah. And you definitely don't have to be, 100% strict. Because I have people that, maybe they're doing just a couple ounces of chicken a couple times a week and they're still having progress. They're seeing good results. So you have to do what works for you. Definitely.
All right. Okay, thank you so much. Appreciate that. That was a great information on showing us about nutrition. Thank you so much. We really appreciate that. Go ahead. Go ahead, Fred.
All right. We're about to I want to give my thank yous. But before we have a commercial from Camille Cook for her lotions. I love this commercial.
Hi, everyone. I'm Camille Cook, the family nurse practitioner, the creator, the developer, the chef, and the cook of crack. Well, Creamy Crack, the addictive, all-natural body cream. I have a background in dermatology and cosmetic surgery, and I created a 98% organic and a 2% all-natural body cream in 2011 for both my son and husband. My son, who suffered from the irritating symptoms of eczema, and my husband, who was a 2-time kidney transplant survivor and who was on kidney dialysis for over 10 years. They both suffered from the dry, itchy, scaly, and flaky skin. And as a mom and a wife, and with a background in dermatology as a nurse practitioner, I couldn't stand back and see them suffer any longer. So I got into the kitchen and started cooking crack. Well, Creamy Crack again, the all-natural body cream. It moisturizes, it replenishes, it restores, it heals and protects your largest organ. You got it, your skin. I have been able to make such a difference in the lives of those people who suffer from the irritating symptoms of being on kidney dialysis or who are awaiting a kidney transplant, and also for those who suffer from eczema. Those people or individuals have suffered way too long and tried too many things to help their skin come back to life. I am so honored and grateful for you to try this all-natural body cream. Again, that's going to help you look and feel better with your skin. Creamy Crack can be found on all social media platforms at Creamy Crack Body Cream, or can be purchased at creamycrackbodycream.com. I look forward to serving you, sharing with you, and making an impact in your life. I hope you'll go out and try Creamy Crack, the addictive, all-natural body cream. Thank you.
That was awesome. I do want to say thank you to everyone. I just want to say this to our patient panel. I want to recognize Somone Washington, Alana Carroll, and Audrey Bella Langston. We thank you for being on the conference. with your story and everything that you have said. Real quickly, is there anything for the panel that you guys want to share real quickly, about 2 minutes, if there's anything that you want to share, anyone from the panel? We just want to say thank you on behalf of Philip. All right.
Yeah.
I would just say thank you so much for having me part of the conference. I have learned so much, and I appreciate the opportunity to share my story and an opportunity to spread awareness and encourage others to register to be an organ, eye, and tissue donor to help people like us who need a second chance at life. And yeah, this was great, and I appreciate the programming, and I hope that we have another opportunity to learn more. Thank you.
Great.
Well, we appreciate you also.
Yes, we do. Yes, we do. Bella, did you have anything that you want to share before we go? Hold on. I'm sorry. Okay. Go ahead, Bella. I'm sorry.
No, that's okay. Thank you. Yeah, I just want to, say thanks to you guys as well for always having me. It's always a joy to be able to share my journey, but more so just what we are all working towards doing here and how we all work in tandem with one another to get this word out. I've been praying for my brother Philip for a long time. For this surgery, because I just feel he is so deserving of getting him to that place. And I feel it coming, and I was telling him, brother, it's coming. You got to get these few little things done. But I've been thinking about him through this whole thing. And when I saw that video, I almost cried. I kind of turned away from the camera for a minute because I'm like, even in the midst of him about to undergo heart surgery, here this brother is in the hospital. I'd have been thinking I'm looking crazy. I am not getting live on camera. But it just shows the genuineness of his heart and his love. It's not even how it's not about self, And that's when I told him, I know God is about to bless you. With his kidney. So we just want to lift him up. I want to lift him up and just thank you guys, Second Chance, and the doctors, and as the rest of the ladies on the panel. I've seen a few of you before, and thank you for what you guys are doing as well. And Godspeed for all of us.
Thank you so much. Also,
thank you, Justin. I just want to say, Justin, thank you for your slideshow and everything. It was wonderful, man. It gave me a lot of more information also. And just like Bella, I do a lot of research on it as well. And every time you hear somebody else say something about it, you learn a little bit more. So I appreciate you, man, with what you did. Go ahead, Fred.
That was I was gonna say the same thing you said. I just want to appreciate. I want to say thank you to you guys. I really appreciate it. And to Faro, thank you for having my back today. It's my first time dealing this with. Like I said, I do StreamYard, so I hope everything went well today. Philip, I hope I did you proud, my man. I hope
you did. You did a great job.
All right. So we just want to say thank you to everyone tonight. All right, and we'll go from there. And I'm real sure Philip is going to give a update on his the surgery and everything. He said he would probably do something live on tomorrow. So everyone just kind of look out, be prepared for him. Hopefully he's out of surgery by now. I'm gonna call him, check on him, call his daddy, and see how he's doing. All right, I believe that's it. Was that it, Tafaro?
That is it, man. Thank you again for the conference. It was really good, and we appreciate everybody.
All right, everybody have a great night.
All right.
Good night. All right. Bye-bye.
Good night. Thank you.
Thank you, Shannon.
Thank you.
Thank you.